Hello, everyone. Thank you so much for joining us today on the Just Ask and Beyond Ask Lessons Learned and a Look Forward webinar. We're excited for you to join us. And before we get going, we're going to go through just a quick logistics. So on the next slide, you'll note that you are muted during the webinar, but please feel free to ask questions via the question panel on the right-hand side. And questions will be answered as time permits. Any additional questions we don't get to will be posted to the website along with this slide deck and recording. And if you've registered for the webinar, you will get a copy of the slide deck and the recording directly to your email. And we also post it to our Beyond Ask website. And then on the next slide, I'm sorry, I also want to mention to complete the post-webinar evaluation, you'll receive that via email. But I'm thrilled to introduce our speakers today. We have Dr. Timothy Mollett, a thoracic surgeon at the University of Kentucky Markey Cancer Center. He's also the chair of the Commission on Cancer and has been our leader here with the Just Ask and Beyond Ask Quality Improvement Project. So we're thrilled to have him with us today, along with Dr. Michael Fiore, who's at the University of Wisconsin-Hildale Professor of Medicine, and he's also the founding director for the Center for Tobacco Research and Intervention. And so with that, I will pass it off to Dr. Mollett.
Eileen, thank you very much. And it's great to have such a terrific turnout and a growing number of folks that are joining this final webinar as we are wrapping up our work with the tobacco treatment and cancer projects that began with Just Ask and Beyond Ask. Next slide, please. It is a real opportunity for us to be able to share some of the preliminary results that have come from these projects. We really wanted to bring this together for both the Just Ask and Beyond Ask program participants. Everyone's been so diligent in their work with this, and I think you'll see some amazing results that are quite successful. I apologize for coming to you from an airport, and but at the same time, I'm excited that we were able to make this work out. So if there's background noise, I will mute as often as I can. Next slide, please. So Just Ask was a project that ran through the course of calendar year 2022. We put this together quickly at the end of 2021 to be the second national quality improvement project run through the American College of Surgeons cancer programs. Our strategies were to gain support of program leadership, improve documentation in the health record, and train our staff and providers through a series of webinars and education programs. We had 93% retention over this year-long project, and it led to publication, which you see a reference in the lower right-hand corner. Our baseline ask rate was 88%, which we were proud of for all of our participating programs, over 700 programs. But the final ask rate had been increased to 97%. And interestingly, we weren't measuring assist rates in this project. We were measuring ask rates, but at the same time, we did collect this data, and originally the assist rates were 43%. And even through a project where we weren't trying to increase assist, it rose to 60%. And so we saw this as a tremendous opportunity for us to carry this project forward. Next slide. And so in 2023, we ran Beyond Ask. And in this project, we ran in over 300 programs. And our goal was to reach an absolute increase of 20% over the baseline assist rate. And we completed this project through the course of 2023, a total of 326 programs in the COC and the NAPBC participated. And again, we had a 92% retention through the course of the project. This time, our baseline ask rate was 88%, and it rose again to 91%. Our focus, however, was on the assist rate, and this again rose from 45% to 68%. Significant increase in assist rates for patients involved in these programs to move into tobacco treatment. And they used several strategies. The top three are listed here, where we saw quit line referral and baseline at 31%, rose to nearly 50% by the end of the project. Brief in-office counseling rose 3 times to 66%. And we would expect that because this is the one that's least resource intensive and easiest for programs to be able to adopt while they may be moving in the direction of getting IT set up or changing resources within their clinics. But in-house referrals to tobacco treatment within the facility of the cancer program rose from 15% to nearly double at 28%. So this we saw as a successful way to utilize resources that already existed within the programs. And I have no doubt that over a longer period of time and IT technology advances and connection with the EHR and all the things that are necessary that just take time, these rates will continue to increase. Next slide, please. So along the way, we developed a series of national resources that we thought were useful, and I'm going to ask Eileen to come back on and talk us through how these resources were used and what some of the responses were from the programs.
Yeah, thank you. So the first side on the left-hand side of your screen here, you'll see what we called our change package. And this was developed during the Just Ask time period. And it's still posted to the website. So I can put the website address into the chat box for folks who are unfamiliar with how to access that website. But what this really was is a toolkit with actionable tools. So, while we can share all the literature in the world of research and things like that, what we really wanted to give you was really actionable tools for an intervention that you wanted to take. Anything from providing the staff clinician training to how to enhance clinical workflows, things like billing and coding and prompts for screening. And so we have kind of all sorts of tools in there that programs could choose from and really kind of implement to take off the shelf. And then in Beyond Ask, we got a little more visually creative, but the same concept here with our roadmap is, the idea was to follow through with these steps. And some people were starting on step one, and that's okay. Others said, we're good on step one and step two. We need help with step three, though. And so we kind of put together this roadmap, and you got to choose your own adventure here with what step you were on, and then the corresponding resources for it. So we were, excited to put this together for you. Again, this is available to everybody via the website, and in a minute, I'll put links to that in the chat box so that you can bookmark it, revisit it often. And once more, if you actually have a resource that you think could be applicable to what the category of intervention is, and it's maybe more of a national resource, we'd be happy to continue to update these resources and make them a bit available for everybody. So please do check them out. Like I said, they're really actionable. So we go beyond just kind of the research and the why, and it's more about the how. If you want to go to the next slide, please. You might recall that at the end of every data collection cycle, we had a comment box that said, share with us the innovations. What did you kind of create or do or expand upon? What did you adopt or adapt during this time period? And we did read those, I promise. And quite a few really wonderful innovations took place. We want to take a moment to celebrate everybody who participated in Just Ask and Beyond Ask, and who innovated and who tried different things and sought out different resources. And we kind of broke these resources up into different quote interventions, so patient education, staff and physician education, community and state partnership building, and then finally workflow and system changes. So like I said, we have these up here on the screen. I'm not going to read them to you. You will have access to the slides and you can certainly read them, but just kind of an overview of what came out of kind of the patient education. What did you guys tell us that you did? And so you might recall on one of our webinars, we highlighted a program who developed these quit kits, these physical kits that had a lot of different tools and resources in them for patients that they can physically hand the patient to say, take this, and we could talk about what's inside this quit kit, but you could take it home with you and look and see what you have. Lots of great education came out of this, patient-facing brochures and pamphlets and videos, public campaigns, smoke no more in 24 catchy slogans. Really, you guys did a wonderful job of educating your patients and making these resources available, and really kind of putting out a public campaign to ask about smoking and assist in smoking cessation. So that's kind of what happened with the patient education. Dr. Mollett, did you want to add something?
Yeah, I just wanted to highlight this one in the lower left-hand corner because it really speaks to the nature of an effective quality improvement project. This program hired a navigator, a lung cancer navigator, and they also tasked them with heading the smoking cessation program. They subsequently took that navigator and trained them as a certified tobacco treatment specialist. And then they worked with the chief medical officer to integrate with regular chart reviews. And so several interventions along the way in this one program. And I think that one of the numbers that I remember from the Just Ask project was over 2,000 interventions were accomplished out of the 700 programs that initiated this project. So just an example of how this looks for solutions, builds on solutions, and allows those to be incorporated using the system within that healthcare project.
Yeah, excellent observation. I also really appreciate that, the ordering the free quitline patient education materials. So that's kind of that low hanging resource free essentially that you're able to use and bring into your clinic or into your care setting. And so, I know budget is tight, right? Finances are tight. And so finding out the resources available to you and, bonus points if they're free, why not? So lots of great work done on the patient education. If we go to the next slide, we're going to highlight a few things regarding the staff and physician education. And again, I recall we highlighted on one of our webinars a program that made training videos, a series of training videos for all staff to watch because they kind of felt like this was the responsibility of all staff. And so, we really thought that was a wonderful opportunity to engage everybody in this work. Some people kind of got staff trained through outside mechanisms like their kind of local Department of Health. Some were able to find grant funding. So you guys got really creative with what was available to you and how to kind of utilize the resources that you had to really embed a lot of the asking and assisting pieces, which will speak to sustainability in the long run. So again, just wanted to pause here and highlight some of the wonderful work that you all did. I think again, it's really important. One group did some training with their medical residents, getting them really involved from the start of why this matters and how you can help. And so I always think that's a great idea to start with residents too and get them on board from the start with how to do this. Our next slide, we talk about community and state partnerships. And again, you all did so much work. You saw kind of in one of the proven strategies up front that, partnership with the quit line, about 50% of you and Beyond Ask kind of started to use that. And so that's fantastic resource for you to use. Referrals to, community programs that you went out and found yourself. We know, unfortunately, with the state of community programs, they're here today, gone tomorrow. And so a shout out and reminder to check in with your community partners, make sure they're still available to you and to your patient population, I think is a really important thing to do, every 6 months, because we don't want to refer our patients to somewhere that is no longer open. And then, things like finding free online tobacco cessation support groups, especially, in languages where it matters for your patients so that, they can kind of receive that advice, advisements is so important. Um, and then finally, something that we know is really difficult to do, but on this final slide here, talking about the workflow and systems changes, and we know that is more difficult to do. Shay, if you're able to head to the next slide. Thank you. But again, you guys rose to the occasion, and there's so many things that you did in terms of working with your IT to identify kind of that pathway forward, utilizing smart phrases in your Epic, redesigning nursing intake forms, and standardizing documentation across the board. Creating systems to trigger follow-up within a certain time frame when a patient who smokes was identified. All of these things are hard to do because you have to, kind of get multiple people on board. You have to, engage multiple systems, but really that's kind of the core of quality improvement, is engaging various stakeholders, making small changes and seeing how that kind of influences your ability to work and to work at a high level. And so there's lots of great stuff that was done here. And again, we applaud all of the innovations that were done. On this next slide, we put out a satisfaction survey because we wanted to hear from you. This wasn't mandatory. It wasn't part of kind of the requirements for participation, but at the end of the day, we want to know what we're doing and how it influenced you. And so we put out this Beyond Ask satisfaction. It went to your primary contact along with the attestation form. If you didn't get it, you could scan this QR code and it will take you to the survey. But again, if you've already submitted feedback or if you did not formally participate in the Beyond Ask project, but are just kind of here to better understand what happened, we ask you don't do the survey. But like I said, we want to hear from you guys. And so what we found was that 89% of you believe you were successful or very successful in assisting your patients, which is a huge number, and 94% of you were feeling like you're able to sustain those efforts. So of the interventions that we just talked about, at least one of them is going to be sustainable for you. And that's kind of what's really important here, is that we're hardwiring in the changes. You told us that the webinars and the REDCap data collections were your top facilitators. Those really kind of helped you stay on track and keep moving forward. But we also appreciate that collecting data at the local level is difficult, as well as changes to your workflow. We know that those are difficult challenges, and we appreciate, and like we said, we had 92% retention, and so so many programs were able to overcome these challenges to get the data, even though we appreciate that it might be time intensive. And hopefully through this project, you've kind of worked on ways to streamline it a little bit or make it a little more focused. And then just going back to those types of interventions that contributed to your success. So interestingly enough, you guys told us your systems focused interventions, that's your workflows, your IT changes, those were kind of, while the most difficult, were also kind of the biggest successes for you, because again, those are pretty hardwired in, and you're able to kind of see the immediate benefits of it. The patient-focused interventions, though, also incredibly helpful, along with the physician-focused interventions. And then finally, our community-focused interventions were again, not maybe identified as the top contenders, but we know that there was a lot of great work that happened around those. Dr. Mullet, want to see if you have any comments here.
Thank you, Eileen. Absolutely. I think this is really important to take a look at this chart on the right side. When we look at where interventions occurred, the majority of the interventions began with patient and physician focus, but yet when you got completed with your projects and understood what was most successful, those difficult interventions where you made changes in the EHR, where you adopted systems-based practices, these were the ones that were most impactful for the sustainability of your program. So I think that's critical for demonstrating the success of an iterative quality improvement project and how you all were able to recognize what was important, not just what was easy. And so I think that's again a sign of a successful program. But I want to pause for a moment to thank Eileen and Shay and the Quality Core for the American College of Surgeons Cancer Programs. Their leadership in this was critical. Their maintenance of the project to keep us on track and develop all these the slides, the webinars, the elements that were put into the website was absolutely critical. Now, I also want to point out a number on this slide, and that's 94% of programs believe that they can sustain their efforts in identifying and assisting patients in cancer patients in tobacco treatment. So I think that's a key indicator for me to be able to see that this is a project that potentially could be further incorporated into several of the standards that we have today, and potentially looking into how tobacco treatment can be incorporated into the Commission on Cancer going forward. It is now, with the next slide, a privilege of mine to introduce a colleague and a friend through this project that I've had the privilege to work with and to get to know. Dr. Mike Fiore, as you heard, is the founding director for the Center for Tobacco Research and Intervention at the University of Wisconsin, and his leadership there has led him to serve the National Cancer Institute in the Cancer Center Cessation Initiative for many years. So now I'd like to ask Mike to go over some additional information on how we can sustain these tobacco treatment programs in our cancer care setting to help us continue to keep this momentum going. Dr. Fiore.
Thanks, Dr. Bullitt. And I want to just start by giving all of you an extraordinary shout out for an incredibly impressive program and set of findings from both Just Ask and Beyond Ask. When I look back on my career in the 30 plus years that I've been working to help people quit smoking, I can't think of an initiative that has really had more impact from the perspective of helping individual patients. As I'll mention in just a moment, one of the most powerful things we can do to help a cancer patient do well is to help that patient to quit smoking. And you did that. You did that broadly across hundreds of centers. And it's just extraordinarily impressive to see the outcomes that Dr. Mullet and Eileen shared. So I want to say congratulations and thank you all for participating. And what I want to do is talk a little bit about some strategies to sustain it, knowing that resources are limited. And as already been mentioned, the slides that I'm using will be available. And while some of them have a lot of information, you could refer back to the slides if that would be helpful to you. Next slide, please. So I want to start, next slide, with a very brief rationale. And it's relates to the issue of the power of helping a cancer patient quit smoking. As the webinars have highlighted, there are few things that can improve the health of a cancer patient who smokes that are greater than helping that individual quit smoking. We know, for example, that a cancer patient who smokes and quits is more likely to survive his or her cancer. They're also less likely to die from all causes. And finally, they'll tolerate their cancer treatment better. So among the reasons to do the program, what's Just Asked and Beyond Ask, are that you're going to help the cancer care of your patients. And it is so powerful, the data that has highlighted the impact of smoking cessation, that we've begun to refer to smoking cessation as the fourth pillar of cancer care, joining chemotherapy, surgery, and radiation therapy. And in some instances, quitting smoking is even greater than some of these other pillars. It highlighting the incredible importance of addressing smoking for all of our patients and the importance of sustaining the work that you've started with Just Asked and Beyond Asked. Next slide, please. So I'd like to talk a little bit about something called the Cancer Center Cessation Initiative. This is a program funded by NCI and the Cancer Moonshot program, which was designed to say whenever a patient came into an NCI funded cancer center, they should get smoking cessation treatment. And 52 of the 65 total NCI designated cancer centers were funded to participate. We at the University of Wisconsin managed this program, and the goal was to take a population based approach and increase the proportion of cancer patients who smoke who receive cessation treatment. And it was designed to be sustainable, not just for the 2 years of NCI funding. Next slide. This slide shows you the 52 sites that received funding from the National Cancer Institute. And as you can see, they rolled out over 3 periods beginning in 2017 with the last period beginning in 2020. And again, the goal was to treat every patient coming into that cancer center who smoked and to check whether they were able to successfully quit. Next slide. Here is the team that oversaw the Cancer Center Cessation Initiative. Initially, it was led by Betsy Rowland, who moved on, and now Dr. Danielle McCarthy leads the initiative. I was a senior scientist. The other members of the team are here, and I just want to give a shout out to Mara Minion, who remains on the team and is a resource both for C3I, but also for Just Ask and Beyond Ask. So I'll be sharing at the end of the talk some of the resources that are available to all of you that came out of C3I. Next slide. So this slide, if you go back one slide, please. I want to now just share with you what the impact was of C3I across these 52 sites, because I think it is a very meaningful way to estimate the impact of your programs as well, based on what we know and based on the similarity between the initiatives of C3I and Beyond Ask. Next slide. So here's the first top line finding. Over the 5 years or so of the program, we have now treated almost 110,000 cancer patients across the 52 sites. It's been a remarkable success, and as you can see by this graphic, it's sustained over time, and we were able to continue to help patients across the 5 years of the initiative. And just to share with you, the initiative is still ongoing and will continue as a NCI program. Next slide. It also was effective. We checked in on the quit rates of the patients, and we achieved a quit rate of over 21%, which is greater than the quit rate of the United States Preventive Services Task Force standard at 6 months of about 15%. So not only did it reach a lot of people, but so many of them quit. Next slide. It was also remarkably equitable in terms of its reach. And I think this has great impact to all of you, because what we've found is that when you provide programs to all of our patients, we help to eliminate some of the inequities that occur with much of clinical care. So as you could see, the purple line on the left, the overall reach was about 16% of all patients who smoked, but we over-enrolled African American patients who smoked, patients of multiple races, and Hispanic patients who smoked. So groups that are often undertreated were overtreated in this initiative. Next slide. It also resulted in reaching patients who either don't have health insurance or patients who had Medicaid health insurance, so the poorest of our patients. We also overreached patients who are part of the Indian Health Service and Medicare patients. So patients who are often left behind With C3I, they were just the opposite of that. They were overreached. Next slide, please. And finally, just to share that we collected data from the 52 participating sites every 6 months for the whole course of the initiative. And we had remarkable reporting by those sites over time. Next slide. So I want to now talk a little bit about the key issue of sustainability and strategies that we identified from C3I as contributing to sustainability of programs such as Beyond Ask and Just Ask. There'll be a lot of information on these slides. I'm not going to describe all of it, but again, the slides will be available at the end of the talk today, and you could refer back to them if it's valuable to you. Next slide. So each program received funding for 2 years, and what we did at the end of those 2 years was to survey what they were going to do to sustain the program. And this was a requirement from the National Cancer Institute, separate from Beyond Ask and What's Asked, but just for C3I 52 sites. But the information we gathered from this data collection on sustainability, I think, is informative about how you could help sustain your programs. Next slide. So some of the things that we measured were what would help you to demonstrate to your leadership that the program should be sustained. And then we asked leaders about what they would use as criteria to sustain a program moving forward over time. Next slide. This graphic gives some of the big picture takeaways from some of our data collection. The factors that contributed to sustainability were, first, economic factors. Was it cost benefit and cost effectiveness? And did it generate revenue? Something very hard to do with smoking cessation programs. Secondly, what were the implementation outcomes? How many patients were reached? And how many of them used the programs? And what were their quit rates? So really important implementation outcomes. And finally, did the program succeed in getting buy-in from both the healthcare system as well as the clinicians and other staff members? Strategies used to achieve these economic implementation and buy-in sustainability matrices include getting leadership buy-in and maintaining that over time, monitoring and reporting outcomes, and participating in initiatives such as the Commission on Cancer's Just Ask and Beyond Ask, and advancing the science of how we can help cancer patients to quit. Next slide. I want to highlight that one of the 52 grantees applied for and secured a National Cancer Institute R01 grant, Ramsey Shalom from the University of Florida. And the purpose of this grant is specifically to assess strategies that lead to sustainability of tobacco cessation programs. This grant is early in its 5-year course, but it will be sharing its results and we'll be sharing them with the Commission on Cancer, as well as on the C3I website that I'll share with you in just a few moments. But it is an important scientific effort to assess whether patients are able, whether programs are able to successfully sustain themselves. Next slide. So we used an assessment tool, and Dr. Shalom is using the same tool that is ways to assess sustainability. And I'm going to be going through each of these 7 strategies used to advance sustainability, highlighting a few of the many strategies that can be used as ways that you in each of your sites, regardless of your size, regardless of your funding or staff, could possibly do. Next slide. The first is engaging staff in leadership. And clearly, in order for a program like this to work, there needs to be buy-in of leadership of the clinical enterprise. But what in particular helps to sustain programs like Beyond Ask and Just Ask are involving a multidisciplinary team with particular inclusion of the HIT staff, which can do changes to implement, as Dr. Mullett mentioned, the systems level changes that allow smoking cessation programs to be built into the DNA of the way a clinical encounter occurs if the patient happens to use tobacco. So engaging all staff, particularly leadership and HIT staff, is key. Next. As Dr. Mullett mentioned, stakeholders, including community stakeholders, are key. And I would say the Commission on Cancer is particularly important in this instance, that will serve as a repository for helpful information for each of your sites and assist you in different ways to help you to quit. But there are other resources, including the American Cancer Society, American Society on Clinical Oncology, and others. I want to just do a special shout out to state quit lines. As I saw in seeing the data from Dr. Mullett, quit lines have been a key part of your programs, and quit lines provide free smoking cessation services to every smoker in that state. And some don't realize that many of these quit lines send to the patient's home free nicotine replacement medications, in addition to offering trained counseling to patients. So even if your program is such that you can't hire a tobacco cessation specialist, you can work to link to the state quit line, and your health IT staff can assist you with that. And the reference that I'll give you at the end will help you with that as well. You could take advantage of the quit line as one of the modes of providing cessation services to your patients. Next slide. You need to make sure your organization is ready both to implement and to sustain. And one key part of sustaining is, so often we hire staff, or we have staff who's assigned to this responsibility, and when that staff person moves on, the program sometimes ends. So to the degree you have a tobacco treatment manual to ensure continuity through staff turnover, you could help ensure that the program is sustained over time. Next slide. As Dr. Mullett reported, system level changes were the strategy that was viewed as most effective in implementing Beyond Ask. And that makes 100% success to me, because if it's weaved into the visit workflow, it becomes an automatic part of the activity, that once a patient is identified as a smoker, there are systems in place that prompt the care team to provide cessation treatments of some sort, or refer the patient to smoking cessation treatments. Next slide. Training and implementation are obviously key. Working with your IT staff, having a number of individuals who have been trained. Continuing education and encouragement of participation is really key as well. Um, we all who work in clinical settings are aware that there's an endless stream of new programs, and all of them are laudable. But what is at risk is important programs like Beyond Ask can fall to the wayside unless there is a specific effort to sustain it over time. Next slide. Monitoring and evaluating outcomes are key, both for the program but also for leadership. To use your EHR to measure program participation and program outcomes, to establish a tobacco registry that reports on the number of your cancer patients who smoke, to track its implementation, and to share the results with clinic staff, clinic leaders, and clinic champions. Next slide. Finally, outcomes and effectiveness. It is incredibly powerful to be able to say, as we were able to say with C3I, that 100 of your patients have quit smoking as a result of this program, or 500 have participated in the program who were smokers when they presented to your program. Those outcomes motivate individuals to continue to refer patients and continue to help people to quit. So outcomes and measuring effectiveness of your program is key. Next slide. So I'm going to end with this slide, and that is the website that shows where you can get additional resources from C3I to supplement the resources from the Commission on Cancer. We too are developing a roadmap which parallels the work that the Commission on Cancer has done and provides links and practical tools for you to help implement, monitor, and assist your patients quit. You could register for these resources, and everything from C3I is in the public domain and publicly available. So I want to urge you to take advantage of it, just as you take advantage of your materials from the Commission on Cancer. So I'm going to end in the same way that I began, and that is to say congratulations to all of you for taking part in what's asked, just asked, and beyond ask as a program to fundamentally change the outcome of your cancer patients. By assisting them in quitting smoking, you do just that, and you give them more hope as they move forward beyond their cancer. So thank you and for inviting me to join you today, and I'm going to turn it over to Dr. Mullet.
Dr. Fiore, thank you so much. Obviously, you've gained a lot of wisdom in this area through your work over 30 years, but and then the culmination of that by initiating and sustaining the C3I project. And I'm sure the audience can hear overtones of the elements of C3I that have been woven into the process that we've initiated with Just Ask and Beyond Ask. And so I think that not only has your information and leadership to guide us been important, but folks should understand that the C3I project and the NCI have partly funded our project to be able to help sustain our work and have led to us being able to have the opportunity to publish this work, but also submit our own R01 grant that is in review right now. And we're certainly hopeful that that's going to have a favorable review that we'll be able to bring that forward. You know, the data that Dr. Fiore shared with regard to the success of the C3I project is the value of a research project that has the incredible ability to collect that much discrete information on the success of the project. What we were running was a quality improvement project, and so it was a bit higher level assessment, same degree of fidelity of information that goes out to the programs, but a different level of responsibility on each of the programs to input that information regarding their patients. But just an example, just as an example of our reach, and with the NCI project reaching over the course of its 50 plus programs that participated, we had a pool from 1,500 cancer programs across the country of all different kinds. And as you heard from the Just Ask project, we had over 700 programs that participated. And that led to over 700,000 patients that were impacted by assessment of tobacco during their cancer care. And while we know that there was a high level of ask rate, and we know that there was a higher level of assist rates that went along with that, and we certainly know that more patients were led to quit smoking through this project. In the Beyond Ask project, over 300 programs participated, and over 300,000 patients were influenced by the Beyond Ask, helping those patients who were involved with, who were happened to be smoking at the time of their cancer diagnosis, to lead them to tobacco treatment. So if you put all of that together, it's over nearly 1 million patients that were influenced by the conduct of these two trials over 2 years. And so I think that's what's really important about these national quality improvement projects that Eileen, Dr. Yang, Shay, and others have led through this quality core. And so I look forward to seeing similar success through the Breaking Barriers project that is being run now, looking at assessment of those social barriers that exist that can influence patients getting effective treatment. We're also running the NODES project, which is studying standard 5.8 on assessment of lymph nodes at the time of a surgical resection of a lung cancer. And then we're looking at other projects going forward to see how this can move. But I challenge all of those projects to extend their reach and to have the breadth that we've been able to achieve in this short period of time. I also would be remiss to say that not only is Dr. Fiore a champion of our project, but also contributing to our task force. We also had other leaders from the American College of Surgeons Commission on Cancer, James Harris, and our accreditation committee, Lori Kirstein, Dr. Kirstein leading our education committee, now serving as the vice chair of the Commission on Cancer. Incredible support staff that we've mentioned with Eileen, but also leading back to Dr. Heidi Nelson as our medical director, providing full support, as well as Asa Carter and Chantel Ellis to help us with this, with the educational efforts. Our subject matter experts ranged from Graham Warren at the University of South Carolina, Jamie Ostroff, Dr. Ostroff working out of Memorial Sloan Kettering, Dr. Burris, Jessica Burris, working out of University of Kentucky in population science, Rachel Shelton at Columbia, Eliza Tong from UC Davis, Audrey Darville from the University of Kentucky, along with from the NCI, Dr. Stephanie Land, who is with the Program of Tobacco Control. So all of these folks had contributed this expertise that we needed to be able to understand how to influence this project. Along the way, we added some special task force members that provided a perspective of the programs. Dr. Karen Arthur is a community surgeon, and Kendra Johnson is a oncology data specialist who helped us understand how this could be implemented at a program level. And Cynthia Burton is a program administrator who helped us to make this all come forward. So these are all team members that stuck with us for 2.5 years, really, to be able to develop this project and see this to the point that we're in today. So it's celebrating all of their input and all of their contributions to be able to help us with this. So I think we have about 10 minutes. I'm wondering if Eileen or Shay see any questions that have come up. We encourage folks to enter your questions in the chat box.
Yes, please do enter your questions in the chat box. We're waiting for them. But I guess, Dr. Mullet, one question I might have for you is, we know a lot of the people and programs participating in Beyond Ask and Just Ask learned so much. I guess we might be curious to know, what did you learn, or what was kind of your biggest takeaway from reflecting back on where we were, plus 2 years ago to current day? Is there anything that kind of feels like a lesson learned for you? You've been in this space for so long, but I imagine you continue to learn.
Well, it's a bit tongue in cheek, but as a thoracic surgeon, I've learned that I can't just yell at my patients anymore and expect them to quit smoking, because that hasn't worked for 30 years. But I've definitely, from the expertise of the colleagues that I've worked with, have learned so much about effective ways to communicate with patients in this vulnerable space that they're in, and to help them with this opportunity to understand how important tobacco treatment is at a time of a cancer diagnosis. And I've always watched my patients come through and talked with them about tobacco treatment and listened to them explain. It's, it's such a stressful time with a cancer diagnosis. I really can't think of tobacco treatment at this time. Um, I've already got cancer. Why do I need to worry about quitting smoking now? All of the things that we listen to, and to really have, through the change package that was created, we've really now got tools that we can respond to those questions with very impactful answers to be able to help them recognize that they can do something about the outcome of their cancer care. They can't change how the chemotherapy is going to work. They can't change how the radiation is going to work. They can't change the nature of the operation that I'm going to do. And so here's something that they have in their hands that they can help with and they can control. And it's hard. It's an addiction. It's a management of a challenging issue. The other thing that I've learned is this concept of developing a team that brings, and it's a diverse team. And that's one of the issues that we are studying in terms of diversity today, expanding the diversity of our cancer programs, diversity of our multidisciplinary teams that we work with, improves the care of our cancer patients. But seeing the diversity of our program in these National Quality Improvement Project has led to more effective recognition of how to empathically and sensitively talk to patients about the nature of their diagnosis. Also, to understand the nature of, we're making a change in a system that's already very busy. These cancer surgeons, cancer physicians are all very busy, and yet we're trying to add, as Dr. Fiore mentioned, one more thing on top of a very busy clinic, on top of a system that's already strapped for resources. But understanding the reason why, understanding that there is an impact of this, and this can save dollars down the road. This can save lives down the road. This can give patients a sense of empowerment and improve the patient satisfaction. So this is something that we've seen, but we couldn't have achieved this without a diverse team that approached it in so many different ways. Primary care doctors, surgeons, medical oncologists, behavioral health specialists, population scientists. Um, the spectrum was remarkable, and we were very fortunate to have all of these folks willingly contribute this time, volunteering their time to be able to see how we might be able to save some lives. And I think we've demonstrated that that can be effective.
Well, that's an incredibly hopeful note, and I like that. It doesn't look like we have any further questions coming into the chat box, and so I'll let you and Dr. Fiore have any final last words or thoughts.
Yeah, Dr. Fiore, why don't we let you wrap up your comments, and then we'll bring it home.
Sure. Just based on the question that was asked to you, Dr. Mullet, I thought myself, and a message I just want to share with everyone that might be a surprise, and that is the proportion of cancer patients who smoke who want to quit. So many of them feel badly about their smoking. They know that smoking may have contributed to the development of their cancers, and how powerful it is for them to take action around quitting, to begin the process of quitting. I think it's helpful in terms of self-esteem, makes them feel better about, you know, their families, that they are taking action against something that they often blame themselves for. So do not be afraid that our patients don't want to hear about this. In fact, they often report that they got better health care if they had their tobacco use discussed. So I would just raise that issue and say our patients are hungry for smoking cessation assistance. Let's take advantage of that.
That's a great point. Great point. Um, You know, I think that the programs have been asking what direction we're going to go from here, and I'm excited to think about the potential of extending further research in this area alongside the American College of Surgeons and certainly including the input from C3I to study this a little bit deeper. Um, I also know that this is so important that it's hopeful that we'll be able to incorporate this into several of the standards that we already have. Um, you know, I think we have prevention standards. Tobacco treatment is often associated with that, but I also know that we have a survivorship standard, and tobacco treatment can be woven into that very easily. And I think that, again, the idea of enjoying a quality improvement project and extending that in some way in your facility regarding tobacco treatment can be continued again as another quality improvement project in your local program. And uh, additionally, I think there's a number of other ways that we can bring this forward: barriers to care, palliative care. So please think about this as a way to be able to put this into your program and comprehensively address it. So I'm going to continue our conversations with our accreditation committee and the other elements of the Commission on Cancer to see how we can hardwire this. But I think that we've made great progress with this project so far, and I'm hopeful for continued momentum. Um, and so I'm on that note, I think I just want to thank Dr. Fiore for his time, both through the projects, but also for today to be able to continue to extend our education and knowledge. Um, who knows, maybe somebody here in the airport's learned a little something about tobacco treatment as well. So maybe it's been useful for that. And I'm again grateful to the team from the Quality Core and all of our task force members for the work that they did. So I'm going to turn this off and say thank you all very much. And Eileen, it's back to you.
Thank you so much. I did put the links to our Beyond Ask and Just Ask website into the chat. You can follow up and contact us at cancerqi@facs.org if you have further questions, comments, and again, give us some feedback, please. Let us know what went well, what didn't go well, what you want to see in future QI collaboratives. We're open to your feedback and really appreciate your time, energy, and effort today. So thank you so much, everyone, and safe travels, Dr. Mullet. Have a great day.